Good morning, everyone, and good afternoon to people in the East. Today, we're going to talk about malignant hyperthermia. Here is the case. Okay, so you have a patient who suddenly actually starts showing the signs. So the end total CO2 has gone up to 60. The temperature has climbed to 39. Patient is tachycardic, is also has low saturation. So what is our differential diagnosis? Okay. So what this patient is showing, although the monitoring is demonstrating that there is hypercarbia, there is tachycardia, there is hypothermia. So looking at these three features, we can think of anesthesia surgery-related diagnosis. And first thing somebody's mind would come in, are we giving enough anesthesia and analgesia to this patient? You can look at whether you're ventilating the patient, or is there a increased absorption because the surgery was a laparoscopic surgery, and sometimes there is pneumomediastinum or surgical emphysema where the CO2 will keep climbing. The other things is the causes. So look at if there is hypermetabolic state because of fever, sepsis, or any of those differential diagnosis need to keep in mind. So if you look at these about inadequate anesthesia, analgesia, yes, tachycardia, hypertension can happen. Respiratory rate can go up in spontaneous breathing patient, but the end-tidal CO2 should not change. The temperature should not change. If you're hypoventilating or there is rebreathing because your soda lime got exhausted or you're using too low flows, yes, you can hypercarbia can cause tachycardia, hypertension, right? And you will actually see on the monitor that the respirator is low. If you are given patient is spontaneous breathing and you have given too much opioids, you'll see that. Yes, end-tidal CO2 will be raised, but again, temperature should not go up. Increase CO2 absorption for any reason. Again, spontaneous breathing patients, your respirator will go up, temperature will not go. Now, coming to fever itself, again, fever can cause tachycardia, hypotension, respirate will go up, and end-tidal CO2 will come down. So you can rule out the cause for that. So there are a number of differential diagnoses for this. Sepsis, again, remains a cause. Anaphylaxis will usually show hypotension. We can look at anesthesia-induced. I mean, Dr. Fadke was talking about this. So anesthesia-induced rhabdomyolysis. If there is a history of thyrotoxicosis or inadequate treatment, so you can look at thyroid storm. Transfusion reactions can cause signal things. One of the common things in emergencies, okay, so not in theaters, but in emergencies, is drug abuse, cocaine, ecstasy or MDMA, methamphetamine overdose, bath salts overdose. In theaters, serotonin syndrome, pheochromocytoma will present hypertension, tachycardia, but not with raised things. Neural malignant syndrome will be again similar thing. It can happen in hypoxic brain injury, and it is also seen with baclofen withdrawal. So these are all differential diagnoses. So when do you actually say that patient has got malignant hyperpyrexia? Because a lot of these things can present with raised temperature, tachycardia, hypertension, raised in end-tidal CO2. So there is a criteria used in the clinical grading scale, CGS, for malignant hyperexia, which was described by Lorac and Rosenberg, also known as Lorac's scoring system. So for these one which are single star, you need to actually only look at one. So you look at rigidities. So generalized muscular rigidity without shivering during or immediate following emergence from inhalation anesthetics, you get 15 points. Masseter muscle spasm shortly following succinal administration, again 15 points. Now, rhabdomyolysis, if it is more CK more than 20,000 units with succinylcholine 15, or 10,000 units without succinylcholine is another 15 points. Color colored unit, that is if patient has been catheterized, 10 points. If you measure urine myoglobin more than 60 microgram per liter, 5 points. Serum myoglobins greater than 175, 5 points. Serum potassium greater than 6. But you have to mark only one of them. Here it is not multiple things. You will only have to score one of them. Okay. Then on blood gases, you look at respiratory acidosis. So with controlled ventilation, if end-tidal COT is going more than 55, 15 points. With controlled ventilation, PaCO2 more than 60 milliliters mercury, 15 points. In spontaneous ventilation, EtCO2 more than 60, and spontaneous ventilation, PaCO2 greater than 65. Then you can use your own judgment where there is inappropriate hypercarbia. Okay, you are ventilating fine, or there's good respiratory rate and tidal volumes, but still CO2 is that inappropriate tachypnea. Again, this is a judgment thing. So you can use a judgment even if those numbers are not correlating. But again, you only use one of these, not you can't have multiple options in that. Temperature itself, inappropriate rapid increase in temperature, 15 points. This again can be judgment, or it can be you can look at temperature itself for your monitoring. So you could actually be feeling for the patient, say that suddenly patient feels too hot. Okay. Or if you're doing temperature monitoring, if the temperature goes above 38.8 degrees, that is more than 101.8 degrees Fahrenheit, then 10 points. Okay. Tachycardia, inappropriate sinus tachycardia, or ventricular tachycardia, ventricular fibrillation, you get only 3 points each of them. Now, the other ones here, you can actually have multiple points in here. So if base axis is minus 8 millicurrents, okay, then 10 points. Arterial pH less than 7.25, 10 points. Rapid reversal of MS signs with dental 5 points. So this is for subsequent diagnosis, that was this really MH? Okay. Then positive family history together with positive personal anesthetic history, uh, 10 points. Resting elevated CK in patient with positive family, 10 points. So these can some of these would be for subsequent diagnosis or post-event diagnosis of malignant hyperparaxia. So anyone who scores more than 50 points, this is almost certain that MH was present. Okay. If it is between 35, 49, then it's very likely. 20 to 34, somewhat greater than likely. But less than 20 is going to be much unlikely to be MH. So this is a good scoring system. You can find this on the internet as well. So what is the sequence of clinical signs in malignant hyperthermia or hyperparaxia? So most frequent signs is hypocarbia, and this is resistant to increasing minute ventilation. So you keep increasing the respiratory rate, increase tidal volume, it doesn't actually come down. It's going up and up. And if the patient is spontaneously breathing, you see tachypnea, or even on ventilator, patient actually over breathing. So it is like if patient is there is discoordination between the ventilation and that what you see when the muzzle relaxants are wearing or patient is trying to. And sinus tachycardia. This is three signs are the most frequent ones, and the usual initial signs others are, especially in children, mesenteric spasm with or without administration of dexamethasone. Then generalized muscle rigidity. You see changes with hyperkalemia, like peak T waves. You can get other arrhythmias like ventricular tachycardia fibrillation. And you can even get asystole in some of these patients because the potassium climbed quite a lot. Hyperthermia is a variable rise. So in some patients, it can rise, especially in children, can have a rapid rise. Sweating because of hypothermia can be also present. Now the delayed signs which can happen is you will probably only notice them once you catheterize the patient, is color-colored urine, that is myoglobinuria, which is happening because of the damage to the muscles or rhabdomyolysis. Patients can go into DIC, and this happens from prolonged or severe hyperthermia, and that is a bad sign because these can lead to death in patients. So coming to definition of malignant hyperthermia or hyperpyrexia. So this manifests clinically as hypermetabolic crisis, like we have already said, and this is present in MS susceptible individuals when they're exposed to trigger agents like volt anesthetics and depolarizing muscle relaxant. It doesn't happen with non-depolarizing muscle relaxants. And this was first described long back in 1960 by Denborough and Lowell. So we have known about this for a very, very long time. So what do we actually mean by MH susceptible individuals? Okay. So MH susceptible patients are the ones who have genetic skeletal muscle receptor abnormalities. And this leads to excessive myoplasmic calcium accumulation when they are exposed to trigger agents. And we'll talk about pathophysiology in a minute. Okay. Now there is a interactions which is going on between the agents, that is triggering agents, and the receptors um, that is involved in the calcium regulation. Okay. And it's seen that there is impaired magnesium inhibition of sarcoplasmic reticulum calcium release or leak, and this leads to extra calcium entry. So there's too much of calcium within the cells. Okay. And there are associations which we always talk about, like scoliosis, very commonly seen in scoliosis in patients with hypotonia, in exercise-induced rhabdomyolysis patients. Patients having strabismus surgery, we were always very cautious. And there are core diseases like central core disease or multi-mini core disease. There's this King-Denborough syndrome, congenital myopathies, there are rod myopathies, and different kind of myopathies are known to. And very rarely it can be seen in patients with hypokalemic periodic paralysis. There is an association, but this is not 100%. Okay. So how common is malignant hyperpyrexia? So MH episode in general population is said to be around 1 in 100,000 administered anesthetic, but this might be an underestimate. A lot of unrecognized mild or atypical reactions can occur. And this happens because there is a variable penetrance of autosomal dominant inherited trait. So MH is a autosomal dominant disease. So if you look at worldwide, there is a lot of regional variability. In some part of the world, it is as high as 1 in 200. For example, in French population, it is almost equal to 1 in 2000. And this may be because of better reporting. And then in Denmark, fulminant malignant hyperexia is seen in 1 in 200,000. But MH is reported in almost 1 in 5,000. In India, we don't know what the incidence is. Okay. So like I said, it is a autosomal dominant inheritance. Male child, there is 50% penetrance in there, and there is a variable penetrance. So not all, even if there is a affected parent, it's not necessary that the children will have MH in 100% of cases. And the gene involved is chromosome 19 for the ryanodine receptor 1 and on chromosome 7 for dihydroxypyridine, that is DHP receptors. Okay. Both these receptors are involved in calcium regulation. And it's now different, where you depends on which article you read. They will likely have different incidents reported. But like there are some who says that in general population it can be as much as 1 in 15,000 in children and 1 in 50,000 adults. And I was previously saying that this is almost is a 1 in 100,000. sorry, I'm just admitting some people. Okay. But because of the, it's a autosomal dominant, it is incidence is more in males than in females. Okay. So can MH happen in patients with previously uneventful anesthesia? And the answer is yes. So it's not always necessary that there is a history of MH in previous. So 50% of patients would have had one or two uneventful exposures to anesthesia before. And there is one case report from the US where there was a confirmed molecular genetic analysis. So there was a DNA positive MH, and this patient had undergone 13 GAs before he triggered MH. So just because somebody has had uneventful anesthesia, I think this was talked about in a recent case which happened in Pune. A patient had had previous uneventful anesthesia and then triggered MH. So this is not abnormal. This is normal thing. Uh, People talk about is gastric muscle rigidity or spasm, or obviously MMR we call it. Is that really a MH? Well, it is a harbinger for MH in 30% of cases. Okay. And it does give a clue that the patient might be a MH susceptible individual. Okay. And these patients, only those who actually develop severe mesenteric spasm are referred for testing. And those who are referred for testing, almost 50% will come back as positive for caffeine halothen contracture test. Okay. So this is seen very commonly in children after suxamethonium. So you do see some increase in jaw tension. This is normal because we know that suxamethonium is a depolarizing muscle relaxant, so increases muscular fasciculation. Okay, so this is normal. And patients who have mild mesenteric muscle rigidity, very few will go on to develop malignant hyperpyrexia. So patients who have increase in mesenteric muscle tone and which can be easily overcome with normal airway management, there is no particular concern, especially if it terminates within approximately 1 minute and there is no association with generalized rigidity. One of the questions I think which was put on the group when I posted about the MMR was how do you manage these cases? Now, in patients who develop the mesenteric muscle spasm, you may not be able to intubate, right? But you would normally be able to manage the airway. So all you need to do is manage the oxygenation and anesthesia. You might want to switch over from the volatiles to the propofol or midazolam, have a clean machine. But if it terminates within a minute, don't worry. Most of these patients do not proceed for MH. But if these patients do develop persistent rigidity of mesenteric spasm, then treat them as MH cases, and you actually go on to the MH protocol. And monitor them. So what exactly happens in MH? Okay, what is the pathophysiology of the MH? So we all know that how the muscle contraction happens. Okay. So there is a depolarizing stimulus. There is opening of voltage gated sodium channels, increase in the sodium. Okay. This happens because of release of the acetylcholine receptor at motor end plate. Acetylcholine binds to nicotinic acetylcholine receptor. Both sodium and potassium conductors increases, there is a end plate action potential generated. Okay, and this action potential from the surface of the muscle, okay, will travel through the T tubules. These T tubules are linked with the ryanodine receptors on the sarcoplasmic reticulum through the voltage-gated sensors. Okay, and when this ryanodine receptors opens up, the calcium is released from the sarcoplasmic reticulum. So we look at this T tubules and sarcoplasmic reticulum interaction and the ryanodine receptors. Okay, so the transverse tubules are linked to sarcoplasmic reticulum. Sarcoplasmic reticulum are the where the the calcium is stored. So here we can look at them more closely. So those are the transverse tubules or T tubules, and those are the sarcoplasmic reticulum, and that is dihydropyridine receptor. So there, like said in the MH, there is changes in the DHP or on the ryanodine receptor. So mainly ryanodine receptor type 1, which are affected. And they're all voltage sensors. I'm sorry, it is people keep actually entering, so I have to actually look at that. Okay. So once the calcium is released, it goes on the actin myosin. There is contraction of the muscle, and after some time, the calcium is pumped back into sarcoplasmic reticulum. So it is released from there, is pumped back. And that's the interaction between actin and myosin is stops and the muscle relaxes. So this is normal. But if this is not happening, right? So if the calcium is not taken back, it's constantly released, then that's what causes MH. So MH is a disorder of calcium control. Okay, so when the skeletal muscles are, in the MH susceptible individuals, when they're exposed to triggering agent, that is succinylcholine or any volatile anesthetic agent, this initiates the abnormal release of calcium from the sarcoplasmic reticulum. Okay, and so this is where this is a failure of ryanodine receptors. They will just keep releasing calcium and they don't take it back, and that's what causes all the problem. Okay, so I've already explained this. This is again looking in a simplistic way. The T tubules are connected to sarcoplasmic reticulum via the ryanodine receptors. That's where the ryanodine receptors are. And there is a voltage gated channel, and that's where everything goes wrong. Okay. There are also sodium calcium channels which are involved. Calcium, which is released from the sarcoplasmic reticulum, is also involved in converting phosphorylase B to A, which then is involved in glycogenolysis. Okay. So it's all about calcium release, and this increase in the intracellular calcium can have both direct and indirect stimulatory effect on metabolism. And like I was showing, there is direct increase in glycolysis via the phosphorylase activation from B to A. There is an indirect increase in demand for ATP, and the ATPs are converted to ADP, and then there's cyclic AMP, which I was showing in the previous picture, and these governs the contraction or relaxation. And because there is hyperstimulation of aerobic and anaerobic metabolism, there is increased production of carbon dioxide. That's why you get hypercapnia. There is increase in lactic acid and hydrogen ions, and that's why you get both metabolic and respiratory acidosis are the features of malignant hyperpyrexia. So what investigations do we do to support diagnosis of malignant hyperpyrexia? Serum potassium, you would set blood samples. Your ABG will actually tell you this. You don't even have to send it to the labs. Blood gas will show raised potassium. You'll see low pH. You'll see base deficits. Okay, and if you send CK and myoglobin, urine and serum myoglobin, they will also come as raised. and I've already talked about them in that. Okay. And almost 100% of patients obviously develop respiratory acidosis. CO2 is markedly raised. And almost 26 to 30% will also have metabolic acidosis because of lactic acidosis and raise in hydrogen ion. Muscle breakdown, rhabdomyolysis, there is release of lots and lots of calcium is released, and this will cause hyperkalemia, which can present as changes on the ECG. You can have T wave changes, you can have premature ventricular contraction, QRS widening as the potassium keep increasing, and the patient can get into VF and even asystole. Okay. Um, Plasma CK tend to rise slowly and it almost peaks after 14 hours. So that's not an early sign. This is for later on. Okay. What causes death in MH? And I had talked about this, that patients who develop going to DIC or end stage organ failure, which is secondary to severe and prolonged hyperthermia and rhabdomyolysis and acidosis, these patients can, have that can happen. It doesn't have to be because of the electrolyte imbalances. This is just that if you're not able to control the hyperthermia or hypermetabolic state, these patients can go into DIC and organ failure, which is bad. So any questions on before we move on to the management? So I'm going to stop for a minute and let people actually ask any questions. So any questions you want to clear?
Sir.
Sorry, who's that?
Hello, Sir Shruti here.
Hi, Shruti, how are you? Yeah,
Good,
tell me.
sir, good. Sir, I just want to know that how the biopsy for malignant hyperthermia is done, from where the samples are taken and how are they taken?
You are
Anything about
you
that?
you're going too fast. We aren't just actually talking about pathophysiology. We haven't come to yet to the diagnosis management. These things happen later on. It does not happen during the acute management. Okay.
Okay, sir. Okay,
Yeah.
sir.
And you need to actually have a center which can actually do those. Obviously, because you'll be preparing for the headache exam. So you need to
Right,
actually
sir.
know that. So we will talk about that. Okay.
Okay, sir. Okay,
That's
sir.
not part
Thank you,
of the
sir.
acute management. Okay.
Thank you, sir.
Yeah. Let me see if there is. So DSP has asked, can calcium glucose be used as anti-hyperglycemic measures apart from GI bypass albuterol? I would actually avoid, because that's a very good question. If a patient is going into cardiac arrest situation, it's a peri-arrest situation, then in those cases, yes. For normal management of the hyperkalemia, calcium would be the last resort. Okay, you would not want to give, because there is already excess calcium release at cellular level. Okay, it's not going to be treated. But if it is going into a peri-arrest situation, that is the last resort, and you want to, then yes, you can. Okay. Do you get that, the DSP? Anil, what causes DIC and any severity? It's a hypometabolic state, which itself, the hypothermia is responsible for DIC in these patients. Okay. So both hypothermia and hypothermia, severe hypothermia, are not good for coagulation. So these patients actually can go into DIC because of hypothermia itself. Okay. Any severity scoring system for that? Like it's not about just the scoring. If you look at which I have already mentioned. Anil, did you get that scoring system, Laura? So it talks about the points, and depending on the points, it's about likely, unlikely, or very certain. That's what is the scoring in the MH. Okay. Uh, Dr. Jayant, no, the priming will not actually help. It's got nothing to do. Priming only helps in preventing fasciculations with succinylcholine, and fasciculation itself is not responsible for the MH. It's a triggering agent in susceptible patients. Okay. Anybody has got any other questions? Is shivering a sign? Shivering is not a sign, Dr. Fadke. It's not a sign of thing. Um, Sohail, you had your hands up.
Yes, sir. I want to ask, sir, the pathophysiology of masseter spasm and malignant hyperthermia are same or little bit different? Any differences?
No, it is actually the same, but I mean, what confuses is that succinylcholine we know is a depolarizing muscle relaxant, so it will actually cause fasciculation because there is contraction actually happens. Now, this contraction of succinylcholine should subside within a minute, but if it doesn't subside and it's sustained, then you start suspecting whether this is going to be a malignant hyperpyrexia. But you're going to look at other signs as well. Is this rigidity? Because in succinylcholine, fasciculation followed by relaxation, isn't it? But if there is rigidity persist through the body, there is no relaxation, and the mesenteric spasm actually persists, then you start thinking this is malignant hyperexia because there is increased calcium release leading to sustaining the contraction of the muscles. Right?
Yes,
You get that, Swell?
yes, sir. Yes, sir.
Okay. So not all mesenteric spasm are MH. You have to see that. And even in the most severe mesenteric spasm, who are sent for the Halithan caffeine contracture testing, only 50% will come as positive. I don't know who this Samsung SM thing is. Does choline dose matter? No, it doesn't. Uh, you don't need to actually give a big dose or anything can, if a patient is susceptible, even the smallest dose of succinylcholine will trigger the MH. Dr. Hemant, yeah,
A very surprising observation of in MH is that everybody knows that dantrolene is the only drug of choice and
yeah,
it is the savior.
yeah.
So people have tried in a susceptible patients.
Mm.
People have tried pre-treatment with dantrolene, which does not help in avoiding the malignant hypothermia. So that is most important aspect. I think as a
Oh,
clinician we should know.
saying that, once you know that patient is MH susceptible or has a history, you can actually have patients on the dantrolene, but it need to be given orally 2 to 3 days before.
Mhm.
And big, so we do actually talk about triggers. I don't know if I've mentioned it or not, but now if you talk about triggers, yes, succinylcholine and volatile anesthetics are triggers, but even stress can trigger
Yes.
malignant hyperpyrexia in patients. So this is called awake MH.
Yes.
And in these patients, starting them on dental in 2 to 3 days, because just the stress of going for a surgery or anesthesia, not everybody takes the same thing. If somebody is going to go, so they will go into stressful situation. So these patients can be started on oral dentrolin. Not you don't actually have to be talking. Oral dentrolin is easily available. Okay, but giving everybody dentrolin, guessing that they might develop,
No.
that is not going to work.
Only susceptible
Yeah,
patients or
yeah,
patient relatives having a history of malignant
yeah,
hyperpyrexia
yeah.
earlier. That has to
That
be.
might, yeah, yeah, yeah. But that is again, I mean, the best thing is to avoid those triggering agent. make sure that these patients are managed well with anesthesia, don't allow stressful situation, including pre-medication, or talk to them and make sure that they're reassured. So those simple things actually work. Okay. The only family history, if you have family history, then in close relatives, treat them as MH patients, MS susceptible patients. Osteogenesis imperfecta is not a risk for MH. Okay, it doesn't come as a risk. Okay, it's a bony thing. It's not. It's more of myopathies, which are important. Okay, so let's move on to the MH. Oh God, guys, are you able to see my whole screen? Dr. Hemant, are you able
Yes,
to
sir.
see the?
Full screen.
Yeah, because it sometimes changes. So we come to the acute management of the MH, right? The first thing you are going to do is call for help. Okay. Now, in India and other places, you may not actually have MH cards, but in UK, we have MH cards. Okay, this was Dheeraj just posted this. We have our own. So I just took the image from there. And there is a list of things which are included in this card. So obviously, the first thing is dentrolin itself. The dentrolin, there are two preparations, and I will talk about them in a little bit more details because that's the most important part of it. It also need to have soda bicarb, dextrose, calcium, lidocaine. Now these are for treating hyperkalemia, for treating arrhythmias. Okay. Then we also need to actually have insulin and dextrose for treating them. Then just generalized equipments like syringes, IV cannulas, NG tubes for irrigation, syringes so that you can do cold lavage if required, and monitoring equipment. Again, so you might actually not have put a temperature probe. So you want to measure the temperature. It can be part of the bladder catheter. It can be nasopharyngeal temperature. You might want a big kit for central line. There are no kits available where you can do cold saline exchange and other smaller things, like for sending samples for blood, uh, and usual things like urinary catheter set and stuff. Those are actually available. So while you're waiting for the thing, you would actually also notify the surgeon and ask him to hold the procedure as soon as possible. They might be doing hemostasis. Let them finish that and say that we are in a situation now, and then we need to treat, and they can. The surgeons can also help then say that, okay, fine, let's get a cold saline. A lot of places don't keep fluids in the fridge, but if you're in a center where you're doing like renal transplant things, there will always be cold fluids in the fridge. So get them. That can be used for lavage. This is something which is in our hands. So optimizing oxygenation and ventilation. You are going to increase the oxygen to 100%, increase the respiratory rate, total volume. Sorry, this should have been 4 and then 5. And you're going to discontinue the triggering agent. So how are you going to do that is there are charcoal filters which you can connect to the machine, you switch off, you have it flushed at high flows. You need to also think of whether you have a fresh anesthesia machine which has not been used at all during the day. Then you can actually you also ask for that. And then we have to think of how we're going to maintain anesthesia for these patients. So we are thinking of total intravenous anesthesia. So this is where we require a lot of people. So that's why you need to call for help. We need to have a lot of people. If you have dental, there should be people who can prepare dentalin. It's not easy to prepare. You need people to preparing your getting machines, preparing TIVA. So there's a lot of things. And the ultimate treatment is dantrolene. And what's the dose? We'll talk about a little bit more about dantrolene. So dantrolene loading dose is 2.5 milligram per kg. So if we actually have an average 70 kg man, we require 175 milligrams, and that is 9 vials. Okay. And you have to actually repeat this 2.5 milligram per kg every 5 minutes till your hypermetabolic states is stabilized. The internal CO2 comes down to less than 50 millimeters of mercury or 6.7 kPa, and the temperature is not increasing, rather it is stabilizing or coming down. Okay. Now each vial of the dantrolene has 20 milligrams, and this need to be uh, reconstituted. So this is a powder. You can see in the image. It is a yellowish powder, and this requires that each of them need to be constituted with 60 ml of sterile water for injection, and that's what takes time, and it's not easily soluble. This also has got 300 milligrams, 3,000 milligrams of mannitol in it, and some sodium hydroxide. So this is why we need. So each patient, if it's 70 kilo person, you are looking at constituting 9 vials, which will take time, and then it's not easily soluble either. So dantrolene is a phenylhydantoin derivative. Uh, it was initially, prepared, or it was available, or is rather discovered, or I don't know, invented for as a muscle relaxant. Yeah. So as I was showing in the image, it is a lyophilized orange color powder, and and it has got 3 grams of mannitol as well, which is actually also useful in the sense that it will also cause diuresis, and you need diuresis in a patient who's developing the rhabdomyolysis. Uh, and the pH is highly alkaline. It's a pH of 9.5. So you need to be careful that the veins you're giving it, there is no extravasation. Otherwise, it will actually cause severe necrosis. Is it not moving? So how does it actually work? So it inhibits the release of the calcium from the sarcoplasmic reticulum. It has got some anti-GABAergic action as well. So it can, if you were to actually give IV dantrolene in awake patient, it does cause a bit sedation. So it does actually help in the maintaining anesthesia as well. I've talked about the dose. Like I said, in acute hypothermia, you need to give 2.5 milligram per kg into a central large vein, and every 15 minutes you can. But initially, you almost repeat it every 5 minutes. The maximum you can go is 20 milligram per kg, but and the literature says that most of the time you control things within 10 milligram per kg. People rarely go about 10 milligram per kg. You can, as prophylaxis, we talked about just now, Dr. Hemant was talking about as prophylaxis, oral dantrolene is available, and you can, this is a 48 milligram per kg per day, and this need to be given 1 to 2 days prior to that. Dantrolene has been used for other things like spasticity and things like that, which is obviously not part of this lecture, but it's used in a dose of 25 to 50 milligrams 6 hourly. And if the patient are on these, then you need to actually know about it. Okay. So this is how the bag looks like once you have reconstituted and put it into a bag of fluid. That is, it looks like. This is just a calculation. So if you divide the weight by 8, that tells you the number of vials you require. Okay. So if the patient is only 40 kgs, okay, so he requires just 5 vials. But you still need to constitute in 60 mLs. So that will be like 300 mLs in a 50 kg person. IV dantrolene hasn't got any significant direct effect on cardiovascular respiratory system, but because you're treating, malignant hyperexia, which is associated with tachycardia, hypertension. So this will affect that, and because it causes the rise in CO2, it'll come down. Um, I mentioned this before. It has got GABAergic effect as well. It can cause sedation, and it is highly irritant. So avoid extravasation. Um, Chronic use in patients, like I was talking about, if it has been used for patient with spasticity, it can cause muscle weakness, drowsiness, and GI disturbances. It is known to cause reversible hepatic dysfunction in 2%. This is more for the people who are appearing for exams, so you need to actually know this. As far as pharmacokinetics is concerned, if they are using oral dose, like I said, it can be used as a preventive measure. So 20 to 70% of the dose is absorbed. And it is 80 to 90% protein bound to albumin, and it is metabolized in liver to active metabolites. So uh, its effect can actually last. Now, there is a newer preparation of dantrolene called Rhinodex. And this is useful because it is 250 milligrams, and it just need 5 ml of sterile water. So you don't actually spend time in, sorry guys, people joining in. So you don't need to actually spend time in reconstituting the dantrolene. Right. So you have 250 milligrams, you mix with 5 ml of sterile water, you get a concentration of 50 milligrams. And the dose required for 70 kg man is the same. So the dose is the same, 2.5 milligram per kg. So all you need to administer is just 3.5 mLs. Okay. And the only thing which is missing on this is the data on the speed and efficacy of treatment, and the need to redose is still lacking. There is if you look at the bottom, I have the website where you can actually read more about Rhinodex. Okay. So this is Rhinodex. So that's all you need. You just need 1 or 2 vials. Okay. Maximum maybe 3 vials. The cost of the 3 vials is around 7,000 US dollars. Okay. So I've actually tried to calculate how much that would be in Indian rupees. So you're looking at around 6 lakh rupees. But greatest advantage is that you just need 1 vial in most cases. And if you look at Indian population, you will hardly find patients who are more than 70 kilos. So the range is around 50 to 70 kilos. So you won't actually require more than a vial. Probably this is a lot more cost effective, but still probably not available in US. So this is comparing the two. So Rhinodex and the usual formulation, and you can look at it. Dose is given, so a 50 kg person requires 125 milligrams, and the oil requires just 1. Okay. Whereas if you're talking about the standard one, you require 7 of them, and you need to reconstitute that. So what's the shelf life? It's a little less than dantrolene. Standard dantrolene is shelf life is 3 years, 36 months. Where for the Rhinodex is 33 months. So just 3 months less than the usual dantrolene. So you have got dantrolene you administered, but most important thing is to cool down the patient. And this is done as soon as the core temperature is more than 39 degrees. You need to be very aggressive with cooling down the patient. Okay. And you can stop cooling down once the patient is down to 38 degrees Celsius. So first thing you do is uncover the patient. Okay. You can give cool fluids. Okay. You can give isotonic crystalloids, 20 30 milligram per kg. You can use ice packs in the neck, the groin, or axilla. If you have circulating water mattress, so there is a obviously heating mattress, but if there is cooling mattress, you can use that. And the surgeons, like I said, can use cold saline lavage. And if the patient has got peritoneal dialysis, you are doing some other surgery, which was not abdomen, but patient has got pain. That can be also be used for cold fluid lavage. So cool down the patient as much as you can. And you need to monitor the labs and treat the abnormalities. And that means you need to, have an arterial cannula. But if you're using a venous sample, it should be without a tunicate. So it's a non-tunicate sample which you need because you don't want lysis of the red cells and you get falsely raised potassium. So arterial catheter as soon as possible to monitor the blood, hemodynamics, but also monitoring the electrolytes, blood gases, samples for creatine kinase for myoglobin. And if the temperature is not coming down or you're having progress, you might also need to send bloods for coagulation parameters, uh, which should include fibrinogen levels and platelet count, because these patients can also go into DIC. Okay. You need to treat the high potassium and metabolic acidosis. So the treatment for potassium, high potassium, obviously the first line is dextrose insulin. 50 units in 50% dextrose can be used as infusion, but you can also use 10 units in 50% dextrose, 50 mLs, and give it pretty quickly, almost over 5 to 10 minutes. For metabolic acidosis, you need to be careful in using bicarb. You can use the one-third correction um, depending on the your base deficit and the bicarb levels. Um, but you know that bicarb will increase the carbon dioxide production as well intracellular. So you don't want intracellular acidosis. But at the same time, you need to ensure that patient is not, uh, you know, patient is acidotic, has got both respiratory and metabolic acidosis. Uh, Bicarb may be required because the patient is developing rhabdomyolysis and you want to protect the kidneys. So in those cases, you might need to give bicarbs, and you need to monitor the urinary pH, and aim is to actually get urinary pH more than 6.5. Um, then cardiovascular support, this is which we already know. You need to give fluids. You need to, ensure that the patient is not developing arrhythmias from hyperkalemia. But one thing you would avoid is giving any calcium channel blockers. So, this is common sense. You're not going to give verapamil or diltiazem to treat arrhythmias. You don't want to block the calcium channel, and there is already increased intracellular calcium. You don't want to actually do that. Urine output need to be maintained. You want to prevent rhabdomyolysis or kidney going into shutdown. And that means that you need to actually maintain urine output at much higher level, 1 to 2 ml per kg body weight. You would be actually giving fluids at a pretty high volume. So you will be probably administering fluid at 200 mLs per hour. So irrespective of whether you're going to do alkalization of urine or not, the volume is most important thing. Diuretics are not. If you're using dantrolene, which has already got 3 grams of mannitol in each vial, that itself will help. But have patient hydrated. Now there are a number of case reports of management of MH without dantrolene from India and some other places as well. And what are the important lessons which we can learn from these cases? One thing is, I asked in the group how many people regularly monitor temperature. Right. Now, temperature monitoring is advocated in any case which is going to be more than 30 minutes, but there is a cost involved. But that does not mean that you can't use uh, other methods of monitoring temperature, right? You can have surface temperature monitoring, which doesn't have, it's a one-time cost. Again. Then is enteral CO2 monitoring. A lot of places in India, they're not still using enteral CO2 monitoring, even for laparoscopic cases. So enteral CO2 monitoring is important in diagnosis. So if you don't monitor temperature, you don't monitor end-tidal CO2, you're going to miss out quite a few cases. Okay. And it's important the earlier you diagnose the MH and institute supported treatment, the better are the outcomes. And you need to have high degree of suspicion when you actually see the signs of hypercarbia, hypertension, tachycardia. Obviously, you would rule out important things. Okay. So instituting supportive measures as soon as possible can save patient. So you will stop the triggering agents. You will take away the soda lime. You will go on a fresh circuit. You take out the vaporizers. You need to actually have charcoal filters. Now these are available, and you should actually every theater should actually have those yellow charcoal filters, which you apply to both inspiratory and expiratory limb, because the recirculation of the agents can still remain. And red rubber, the black, those tubings I've seen still people use it in setups that need to go away. You need to have fresh circuit instituted. Cool patients down, easily done, right? So you need to have ice packs that again can be there in every theater. You can have some fluids in the fridge, and you know, so this is again easily done. You need to correct metabolic acidosis, but like I said, be careful. You don't want to be putting in more carbon dioxide and causing more intracellular acidosis. But if you have blood gas monitoring, and you can then do a correction, do one-third correction, you need to support the renal function. And this is simple as giving plenty of fluids. You don't actually have to give diuretics. There is, if you're using, well, in these cases, we don't actually have dantrolene, but you can actually think of maybe mannitol, but no. And then manage rhabdomyolysis. So let me stress again what you need for rhabdomyolysis is fluids going at 200 mLs per hour. I guess balanced salt is required. If you need to do alkalinization, you need to mix 150 milliequivalents of bicarb in 1 liter bag, and you need to monitor the pH of urine, which is should then go up to 6.5. Okay, but this is not a priority uh, uh, as such. Preventing is yes, so you don't want, if you treat MH, you will then prevent rhabdomyolysis as well. But just giving fluids at good volume can protect the kidney and kidney going and shut down from the myoglobin. Supporting circulation, this you all know very well. And you need to be aggressive in treating hyperkalemia. Use dextrose insulin liberally to bring the potassium down. Um, so the standard is 50 units and 50% dextrose over 50 minutes, but you can use 10 units of insulin in 50% dextrose, 50 mLs pushed over 5 to 10 minutes. So be aggressive in monitoring that, because it is hyperkalemia which can lead to uh, ventricular tachycardia, ventricular even asystole, and all kind of arrhythmias. I talked about this recently about magnesium sulfate. There are some data in saying that you need to give magnesium. Magnesium also is required for effectiveness of dantrolene working. So patients who are hypomagnesic or who have hypomagnesemia are not going to respond as well as those who actually have normal magnesium levels. If you don't have dantrolene, still give magnesium sulfate. Magnesium sulfate does relax the muscle. It also reduces the effect of calcium. Okay. So magnesium is important. Okay. So I'm going to stop at this, because next we're going to go to the aftercare, where we'll talk about what we do once we have actually treated these patients. Okay. So question answers time again. Any questions? Yes, Sohail.
Sir, why we have to avoid calcium channel blocker like diltiazem or verapamil?
Because that's not what happens in calcium channel blockers. When you actually give them, you are going to increase the intercellular calcium levels. Okay, then already calcium levels are actually high, intercellular calcium levels are high. That's what is causing. Okay, so you don't want to actually give calcium channel blockers for treatment of the cardiac arrhythmias in these cases. But uh, if the patients are already on, you can't do anything about it. Some patients will be on that. You can't. But if you need to use calcium channel blockers, you don't use it. Dr. Hemant is there. He can actually tell us more about it.
Right, calcium channel blockers are not indicated in this.
Yeah.
I was just wondering whether you came across any case report. I at least I didn't come across anything. But use of cardiopulmonary bypass to cool the patient, because
Yeah.
the main
And there
thing
is.
is get down the temperature as early as possible, because the organ damage is very high. So,
Yeah.
and
So
it
there are,
helps
sir,
in,
Dr. Hemant, there are, ECMO is mentioned. So
is
putting
it?
on ECMO or in a bypass,
Yeah,
obviously, that's what it
that
is.
is it.
You're
That is
not
it
going to do
because
a thing, but yes, low temperature, that is actually
yes,
mentioned in cardiac centers. If you
yes,
actually have that
facilities.
facilities, go for it.
That's true. That's very life saving actually in these conditions.
Hmm. What was DSP? Any recommended to prevent MH to occur, like avoiding prescription drugs in some group patients? Tajinder, you can come in, and DSP, you can come in. Tell me what you want to ask.
So, good evening, sir. It was a
Good evening. Yeah.
brilliant lecture, sir.
Yeah.
So, in high risk group of patients, maybe in pediatric or any patients where chances of malignant hyperthermia is more, do we can prophylactically avoid any muscle relaxant and go for TIVA?
Yeah. I mean, that is said, but one of the things which is mentioned is that the stress is enough to actually cause the MH in patients. But you're right. I mean, TIVA can be used in susceptible patients in avoiding these drugs. Suxamethonium, like we're using less and less of suxamethonium now in patients.
Yes, sir.
In pediatrics, you can actually intubate patients without suxamethonium. Um, so yes, that is true. I mean, you know that the triggering agents are simple. There are only either suxamethonium or volatile anesthetic agents, right?
Yeah.
So avoid
This,
avoid them. The other is stressful situation in these patients. So you can actually trigger malignant hyperexin susceptible patient without them coming to the theater.
if I can add some
Yeah.
more, if
Yes,
the
doctor.
patients are known to have a MH and some history of MH in those patients, just avoid general anesthesia. Go for
Exactly.
regional anesthesia, and never reported xylocaine, bupivacaine, and with
So
other.
saying that
Absolutely,
Dr.
sir. Absolutely.
Heyman, there are case reports of MH with lignocaine. I don't know how
Is
true
it?
that is, but there are some case reports of MH with But
So we
again,
are
I
left.
think one of the things when we talk about the MH in the Indian subcontinent, the reason why we may not still be seeing as many is because a lot of these patients actually undergo surgeries under regional anesthesia.
Correct.
I think the regional anesthesia is maximally used in Indian subcontinent than anywhere else.
Yes.
So by doing that, you're already avoiding the triggering agents. So even if they're susceptible, you're going to avoid it. There is a question by Sangina Ranjit about how do I decide if I go for alkalizer diuresis for rhabdomyolysis and my urinary pH. Right, you don't actually have to have urinary pH. You can actually use dipsticks for that. So what is the indication for rhabdomyolysis? First of all, this is in general, right? This is a hypercalcemic state, so there's supposed to be no hypocalcemia, so it's fine to use them. The pH has to be less than 7.5 and bicarbonates less than 30. Okay. Uh, so you actually decide on that. If you actually see the patients having the urine color discoloration, like I said, cola colored urine as it is called, you see changes in that, just go ahead and do it. But like I said, you need to be careful in these patients. The primary aim is to treat malignant hyperexia. So till you get normalization of your end-tidal CO2 and temperature, that becomes a secondary thing. You're not going to actually treat rhabdomyolysis first. Do you get that point? It comes later on. But what you do is you actually give plenty of fluid so that the kidney continues to be flushed. Thank you, Anil, for answering that. Any other question? So we are now coming to the last part of the lecture, which is on the ongoing care. Okay. All able to see the screen? Dr. Hemant, the whole screen visible?
Yes, I can see.
Yeah. Okay. So obviously these patients, despite the fact that we have controlled everything, we are not going to extubate the trachea in the theaters because they might still require ventilatory support, and they still have got some amount of metabolic derangement, and they require hemodynamic monitoring. So they need to be admitted to intensive care. You don't, but that's not the only reason. The other reason is that we have to continue the dentalin treatment. So we can either give dentalin as 1 milligram per kg IV bolus for every 4 to 6 hours, or it can be used as a continuous infusion of 0.25 milligrams per kg per hour for at least 24 hours after the last signs of MS seen. And the reason for this is the recurrence of MH, which is actually seen in approximately 20%. And this can actually can happen almost up to 13 hours after the initial reaction. So even if you have actually sorted out everything, you can actually have recurrence of MH, and that's why it's important that these patients are actually kept or monitored in the critical care. So when do you stop dentalin infusion? So you need to have metabolic stability for 24 hours. The core temperature should have remained less than 38 degrees. CK has stabilized, not increasing anymore. There's no evidence of myoglobinuria, and there is no muscle rigidity. In that case, you can actually stop the dentalin infusion or repeat dosing of insulin. The mortality, despite knowing about MH or diagnose MH and use of dentalin, is still 6 to 10%. And this is probably related to the late diagnosis, also related to that we still are using the usual dentalin, which takes time in the reconstitution. The other thing which was probably known but not acted upon is that you require normal level of magnesium for dentalin to actually work properly. So ensure that patients actually do get magnesium sulfate, 30 to 50 milligram per kg of magnesium sulfate in the IV fluids. Just put it into a bag of fluid and run it. Okay. So in patients where there is no temperature monitoring, the likelihood of patient dying is almost twice as in those who have temperature monitoring, for a simple reason that the hyperthermia is detected late. So it might be the surgeon saying, "Oh, these patients feel a little warm," or you actually accident touch this thing and then you take the temperature, and so it is important that temperature monitoring is done regularly in surgeries lasting about 30 years. I actually did ask what kind of temperature monitoring people use, and then say, oh, a lot of them use skin temperature monitoring. Now, patients who have skin temperature monitoring are at least 1.5 times more likely to die compared with those who have core temperature monitoring. So having a core temperature monitoring using thermistors or nasopharyngeal or esophageal temperature is a lot more than. And death seems to occur in patients who have a peak temperature of more than 38.9 degrees, so almost going to almost 39 degrees. Okay. So what else is necessary if the patient has come out? It's important to counseling of the family, the patient and family after acute MH is important. And testing for MH susceptibility should be offered to both the patients and the family members. And I was talking before we started lecture that this is not easily available in India or Indian subcontinent, but genetic testing can be done. Okay. So until definitive testing for MH susceptibility is done or is completed in the patient or in the relatives, if the relatives of the close relatives of the patient are to have anesthesia, then they should have anesthesia without triggering agent or not have anesthesia at all. Okay, general anesthesia at all. That's what I meant. So, and they need to actually have a identification bracelet, like MediAlert bracelet, that they are susceptible. And all the family members, close family members, need to be informed. So, like this case which happened in Pune, it's important that the rest of the family members, whether they're been diagnosed or not with MH, they need to be told that they are susceptible patients. So they should be treated as if somebody is a susceptible patient and treated accordingly. Okay. So all blood relatives are important that they could actually have susceptibility. Now, there are no practical MH screening tests for general population. Again, in this case, I was reading about from Pune. The doctor relative from Delhi said, "Oh, why was this patient not tested for MH?" No, we do not actually have any practical method of MHS screening in general population. Leave alone general population, there is no MHS screening process in for patients who have developed MH. So she is so ill-informed, probably reading about what happens in US and UK and the European countries. Now, in India, it's not available at all. And testing for MH is indicated only in patients with an event uh, suspicious of MH or patients that are MH, and in family members of patients who have tested positive. Okay. So what are the tests we do? So if there is a clinical suspicion of MH or there has been MH, you can do the muscle biopsy, the in vitro contracture testing. So it is done for halothane and for caffeine. So MHS is halothane caffeine, MHS for halothane or MHS for caffeine. So they can be negative, so that's good. So that's MH negative ruled out, but they can be susceptible if it comes positive to the halothane caffeine or caffeine halothane individually. And if they are positive, then you can actually go for DNA screening, but you can also directly do DNA screening in patients with clinical suspicion. So they could come as diagnostic variant identified. Like I said, you need to look at the gene 9 and 7, okay, 19 and 7, and then you can actually look at other variants as well. So this is how the testing is done. Now, once you do the in vitro contracture testing, so it is the patients can divide into three groups. So they could be either MH susceptible, they could be MH equivocal, so we don't know. Okay, may or may not be, or they can be non-susceptible, which is fine. Okay. Now, the halothane caffeine contract testing can give 20% false positive. They are newer test. Now there is a ranodine contracture test, but again, hasn't got very high efficacy, but can be used in conjunction with the halothane caffeine contracture testing. But there is something called chlorocrystal contracture test, which has got much higher accuracy, so almost 100% accuracy. So that is a newer development in testing. So how is the testing done? This was one of the questions actually asked. The biopsy is taken from the muscle, and the biopsy, the no local anesthetic should be infiltrated into the muscle. You can infiltrate into the skin, so it can be done under GA with TIVA, or if you're doing under local, then lignocaine should be infiltrated only in the skin. There should be no infiltration of the muscle. The sample is taken from the vastus medialis or lateralis, um, and then it is subjected to stimulation for every 10 seconds, and then you record the contraction forces. Okay, and then you introduce the samples to halothane, or so number of these samples from the muscles which are taken are then subjected in different settings to halothane or to the caffeine. And how much halothane we use in this one? This is around 3% halothane actually used. This is a halothane contraction testing response. Okay. And a normal response is contraction of less than 0.5 grams. Okay. So if it goes to more than 0.5 gram, that means there is release of calcium, uncontrolled release of calcium, so they will go into higher contraction. Okay. Like in the first case in the A band, it has gone into 1.2 contraction. That means this patient is obviously MH susceptible or is got MH. Okay. So in summary, we will go through the what we have discussed till now. Obviously, we've gone through the pathophysiology and how they present, the clinical signs which are present. Okay. Somebody asked if the shivering is not. It's not shivering. It's sweating, which is actually the sign. Rest of sign we discussed about hypercarbia, tachypnea, sinus tachycardia, and mesenteric spasm, generalized rigidity, then ECG changes, acidosis, mixed respiratosis, hypothermia, obviously, and sweating. We talked about management where the dantrolene remains the drug of choice, okay, but we can cool down the patient, hyperventilate the patient, take away the triggering agents, okay. Um, like I said, you need to administer the dantrolene bolus dose, which is almost 9 vials for 70 kg person, and you need to continue this for at least next almost 24 hours at least, because relapse can actually happen within 12 to 13 hours. There is newer preparation, Ranodex, which is single vial, and it is 250 milligrams. So you dilute with 5 ml to get 50 milligrams per ml, and all you require is probably just 3 ml in a 70 kg person. And you look for reversal of the temperature as well as end-tidal CO2. And then you treat hyperkalemia as you would normally do. You can also treat patients for rhabdomyolysis. But when things go wrong, you need to actually, if there's going to be a cardiac arrest, then you go ahead and treat them by the ACLS protocol. And post-op care, ongoing care, the patient need to be admitted to IC for 24 hours monitoring because of recurrence and because of the rhabdomyolysis treatment or patient going into DIC. And like I said, once the initial MH is controlled, we need to continue administering the dantrolene. Uh, Either you can give us as a regular 4 to 6 hourly, or you can actually have infusion going at 0.25 milligram per kg per hour for at least 24 hours. Okay. So with this, we'll end the lecture, and it's time to more question and answer sessions. Okay, guys, so you can actually comment.